I'd just like to give a very brief introduction firstly to both Penny and myself. My name is Andrew Searles. I head up the Health Economics team here at Hunter Medical Research Institute, and my colleague Penny Reeves also helps to run the Health Economics team here at HMRI. And in 2018, we were engaged by the Australian Health Research Alliance to undertake one of their rapid translation projects. And the particular project that we were asked to look at is how could we improve the local level evaluation of healthcare in Australia. We did this particular project with a raft of expertise from around the country. Apart from Penny and myself, it included Marie Gleeson, Christine Jorm, Stephen Leader, Jonathan Carnan, Harriet Hiscock, and Helen Ferris, and Michael Daly. This team were an expert panel that not only oversaw the project that we undertook, but they also provided guidance to a framework that we developed. So Penny, could I hand over to you to start the first part of the presentation?
Thanks, Andrew. So we're just going to talk about the background and some context for the project, and then Andrew is going to discuss the findings and what's next. So just some definitions so you can understand where we're coming from. So health technologies, for the purposes of this project, had quite a broad definition. So apart from the usual medicines and pharmaceuticals, we were talking about models of care, health policies, tests, procedures and diagnostics, health administration, and medicines and devices. But for the purposes of this project, and given that evaluation at the national level encompasses devices and medicines really well, we wanted to focus on these other types of technologies that exist within local health services. So what do we mean by local level? So for the purposes of the project, we were interested in talking to health services that could be at hospital level or regional health services, districts, where health services are being delivered. And the reason for the focus on local level was because we wanted to understand local context and understand why that's different in local health service decision making, different disease burdens, demography, and socioeconomic variables. So for example, here in the Hunter, New England area, we have quite a wide-ranging populations. We've got metro, we've got rural, and we've got remote, and making health services decisions in the health service across all of those different populations is important. So why do we need more evidence-based decisions in healthcare? Well, there's a few reasons. Essentially looking at sustainability of healthcare expenditure. So at the moment in Australia and in other Western countries, spending on health is greater than the growth in gross domestic product, in how much a country is producing. So we know there are existing inefficiencies and inequities in health spending, and we don't always know that our spending choices are returning value, and it's important to understand that. We understand that there is significant wasted expenditure in health. So estimates from the Productivity Commission and AHW suggest that out of the $180 billion spent in healthcare per year, around $36 billion of that is wasted. And so it was the team's view that looking at local level decision making and evaluation would allow us to look at ways to mitigate that wastage. So the problem, so while some healthcare technologies, as I said before, medicines and devices, for example, are evaluated really well with world-class decision-making processes at the national level, that's not translated at the local level, and many technologies such as models of care are not assessed for effectiveness, and they're certainly not assessed for cost effectiveness or affordability given local context. So we were guided by some advice that came out of the Productivity Commission a few years back, where government subsidised healthcare treatments that have not been formally assessed for clinical and cost effectiveness. So we were looking at how we could impact that. So some specific comments from the health services that we spoke to when we were undertaking the project, emphasising why it's important to take into account local context. So, for example, too often a technology or a model of care is being seen as effective in one jurisdiction and is just adopted in another without taking account of that local context. And decision makers ask for evidence, but the standard of evidence provided is variable. So we spoke to some health services about the types of evidence that they are comfortable informing their decision making, and the range is quite considerable. So what we found was that existing centralised models work well for those nationally provided and funded technologies, but where there's local decision making around models of care, there isn't the same rigorous decision making process. So the solution, as far as we saw it, was that improving local level evaluation would assist in making better decision making and ultimately result in more value delivered for healthcare expenditure at the local level. So Andrew's going to talk about the specifics of the project.
Terrific. So thank you very much, Penny. So in this slide, I'm going to give you just a very high-level overview of the way that we actually approached the project, and starting with the aims that were provided by AHRAA, the Australian Health Research Alliance. So firstly, we were asked to review and report the evidence on the models for evaluation, gaps in the evaluation that was undertaken, healthcare evaluation that was undertaken in Australia, and thirdly, to identify strategies that could be used to improve evaluation in this country. The second aim we were asked to address was to come up with a framework that would improve evaluation and implementation in Australia. So the way that we did this was firstly to undertake a targeted literature review. So we did this, as I mentioned earlier, this was a rapid translation project. So we had 12 months from start to beginning. So we were doing the literature review at the same time as we were conducting consultations around the country. So we spoke with health services across Australia in each state and territory. And also at the same time, we embarked on a process of coming up with a framework to improve evaluation and implementation. And that was designed with the help of our expert panel, and the members of that panel were on our very first slide, and they're all authors of our report, and they're all authors of this presentation. So in terms of the outputs from the literature review and the consultations, we identified models for evaluation, gaps in the evaluation of healthcare in Australia, but also some strategies to improve evaluation. And from our framework design, we came up with two levels of the framework. And one was a very high level, one single page identification of what this framework might look like. And the second component of this project was to come up with a very detailed framework that went down into, I took deep dives into all the various aspects of the framework as to what it might look like if this was to be rolled out in a particular health service. In terms of the outcomes from our work, we came up with a report of the findings, which was released last year and presented at the NHMRC, and it's just recently been made available on the New South Wales Regional Health Partners website. We also, as part of this project, identified 10 core problems associated with evaluation in Australia. We also identified actions for each of these problems. In terms of the framework, as I mentioned earlier, we came up with both a high-level overview of what the framework would look like, but we also provided the detail that went with that. And we came up with 4 national recommendations. So just at the outset, a comment I would like to make here, and we're going to repeat this a couple of times in the remainder of the presentation, is that what we were talking about is actually having a set of national guidelines in terms of evaluation, but the execution of that evaluation is done mostly at the local level. And hopefully, as we go through the remainder of the presentation, that will become clear as to the message that we're trying to get across. In terms of what I'm going to present today, I'm going to identify the 10 core problems. I'm going to show you the high-level framework, and I'm going to reveal the 4 national recommendations that came out of our project. So in terms of the 10 core problems, one of the core problems that came up through the consultations, but also in the literature, is that there is no agreed framework for evaluation or implementation in Australia. A second problem is that there is inconsistent access to evaluation resources. Some health services told us, because of their affiliations with medical research institutes or universities, that they had reasonably good access to evaluation resources, but others said that they had no such relationships and therefore they had a gap in their ability to do evaluation. There was also inconsistent ways in introducing new technology. Sometimes you were told it was through opinion of maybe senior clinicians and sometimes politicians. Other times, the introduction of new technology was based on evidence, and that's of course as it should be. But we were given examples of where new pieces of technology were brought in because senior people within the service thought it was a good technology to be brought in, and as a consequence, health services had to do their best to introduce that technology, even though there was at times a lack of evidence in terms of its effectiveness and cost effectiveness. Another problem is that low-value care is still a problem in Australia. The issues that were raised with us is how to identify it, how to evaluate it, and then how to implement policies to disinvest from low-value care. A fifth problem was around stakeholder engagement, and this is something that we don't do particularly well in Australia, and we rarely do it when we're evaluating a new technology or a new model of care. The sixth problem was that the community knows very little about the relationship between evaluation in healthcare and decision making. And the problem here is, of course, that it opens doorways for other non-evidence-based pathways to influence decisions. The seventh problem is that there is insufficient capacity building in evaluation and implementation. So the issue that we're raising here is that many of the people that come through as potential evaluators for health services are not quite used to working in an environment where the data that might be available for some national or even state problems is not readily available at the local level. The eighth problem was around funding for evaluation. And some of the issues that we were told about here is that some health services did have the opportunity to build up their evaluation and implementation staff profile and expertise in this area, but because funding was unstable, they often had to let these staff go, so they couldn't keep consistency in the skill base. The ninth problem was around sharing information that was related to evaluation. And here we're talking about sharing information both vertically and horizontally. So horizontal sharing refers to local health services sharing information perhaps on evaluations that they're doing or have done, whereas vertical integration is about making sure that any local level evaluations that are undertaken are actually escalated up the chain so that both the state and the Commonwealth have visibility of those evaluations and what was found. And the 10th problem was that evaluation outcomes are often not meaningful to decision makers. And for the health economists that might be listening to this presentation, unfortunately, and I include myself and Penny there, we were told very clearly that the reports that come from health economists are often not understandable by the people who need to use them for decision making. And this was identified as a major problem. And as a consequence of not understanding them, people didn't use the information contained in those reports. As a part of our project, our working group identified actions for each of these problems, and some of these actions were doable in less than a year, and others required a more strategic delivery over a 3 to 5 year period. I'm now just going to briefly show you what the high-level evaluation and implementation framework looked like. I'm not going to go into the detail, but one of the reasons that we came up with this is that we were asked by numerous health services, was there a simple diagram or a simple one-page explanation of what evaluation might look like over the life cycle of a health technology or a model of care? And so what we put together was based both on the literature, but also was informed by the consultations, was what you have up on the screen in front of you now. And so the first steps, of course, are around on the far left-hand side around evidence gathering. So this includes understanding what the need is. What is the demand for this new technology or the model of care? It's also around identifying the problem it's going to solve. It's around priority setting. It's also about finding suitable healthcare models. Do we need to develop something new, or can we actually import something that's existing, that's already out there, and bring it into our local health system? And it's also around evidence synthesis. It's knowing what knowledge is already available that we don't have to duplicate. The next step is around initial research and evaluation. So this is where we would be evaluating either the model of care that's been designed specifically for our health service or imported. It would include doing the statistics and the health economic assessment. And you'll see in brackets there that we've identified budget impact. And this is actually a way that we can improve the communication of health economics to decision makers, is to actually incorporate that into a budget impact statement. It also includes risk assessment and making sure that the outcomes of this are passed to the decision maker, which is in the next square. So the decision maker then can consider the evidence, decide whether they're going to adopt, adapt, retain or remove the healthcare. There might also be information in doing the evaluation that can assist in procurement. And there we use some of our own on-the-ground experience with some of the evaluations that we've done, where we identified information that those who are purchasing particular technologies would benefit from. And one of them was around the cost of catheters. The example that we have is that we're working across a number of health services, local health districts here in New South Wales, and we identified that they were paying quite substantially different prices for exactly the same unit. And in fact, some of the larger health services were paying the highest price. So there is information from the evaluation that could feed back into procurement. The next square is around optimisation. And this, is apart from implementation, is also about making sure that we monitor and evaluate. We want to make sure that the expected benefits that we anticipated from the evaluation actually materialise. The very last square on this particular diagram is around discontinuing low-value healthcare. And at any point in the cycle, healthcare is likely to become obsolete. This also might be that we have healthcare in the system that's never been evaluated and is low care. And so here at this point, we must identify that healthcare, and that feeds back into the optimisation square of where we need to make sure that we implement an appropriate pathway and we monitor and evaluate it to make sure that that healthcare or that technology is actually removed from the system. The cross-cutting themes here, I'm not going to go into them into detail, but they reflect a number of the core problems that were identified to us. So end user engagement, making sure that we've got the right skill sets and the right data resources to do evaluation and implementation. It's around capacity building, it's around information sharing, and it's making sure that translation and scalability are built into the process. But in outlining the life cycle of health technology in this way, one of the things that becomes really quite clear is that evaluation and implementation are not just individual points on that life cycle, they are actually spread across the entire life cycle and they go hand in hand. The next slide I'd like to talk to you about is the national recommendations. So mostly we've been talking about local level evaluation in terms of what local health services can and would like to be able to do. Now, with the national recommendations, what we're doing is setting this into a national framework. The first recommendation that we identified was coming up with an expert panel or a national advisory committee to make sure that we do have a national approach to the way that local level evaluation is done. So this could be, for example, for advice on methods, and it might also be for recommending a particular curriculum to support skills development. And that's to make sure that we have some standard skills that are delivered when we're capacity and capability building across Australia. The second recommendation was around boosting education and training and professional development. So this is not just about the new workforce that's coming through our university system at the moment, but it's also enabling our existing people within health services to upskill to be able to do evaluations. This particular recommendation is around making sure that we build in consistency in the core skills that are being shared in training environments. The third recommendation is making sure that we have the skilled services or the skilled workforce available where it's needed. Now, this might not necessarily be sitting within a health service. It might be an affiliated organisation such as universities or medical research institutes. But the core objective of this, this particular recommendation is to make sure that that skilled workforce is available to health services. And the last recommendation here is around addressing the haphazard funding that we have for evaluation and implementation in Australia. And as you can see from that, last recommendation, it's around making sure that we have sustainable funding so that when health services build up a skill base in evaluation and implementation, they're able to maintain it and they don't have to go through this upsizing and downsizing that we were told about that's quite common across Australia. So in terms of the main messages from the work that our team were involved in, and when I say our team, I mean the national panel that everybody had input into the work that we were doing. The first message is, of course, to note that Australia does have some excellent centralised evaluation models. Penny mentioned before about Pharmaceutical Benefits Advisory Committee and MSAC. So these national bodies work particularly well when we have a nationally funded technology. However, there is a gap in the evaluation of healthcare when it's delivered at the local level. And this is where we need to take account of local context. Our recommendation here, and one of the key messages, is that this is around a combination of centralised standards but decentralised execution. Addressing the gap has the potential to increase the likelihood that we're going to have cost-effective healthcare entering and staying within the health system. And better evaluation at the local level is a mechanism to increase value from health spending. And given, and I think we identified this earlier, that most of the health spending in Australia occurs at the local level. So approximately 70% of the 180 billion that we spend on public and private healthcare in Australia, about 70% of that is at the local level through local health services, through hospitals and through primary care. So in conclusion, the work that we've just been describing to you addresses, firstly, a challenge that was raised by the Productivity Commission back in 2015, and that was a challenge to improve Australia's evaluation of, to improve Australia's evaluation architecture. And secondly, it addresses one of the MRFF priorities, which is around comparative effectiveness. So with that, I would like to thank everybody for listening, and I do hope that the IT has worked and that you have been able to hear us. We will now open for questions, and I believe that they are going to be sent by text messages from Sarah. So we're very happy to take questions.
Rachel, are you going to try and talk? And let's see if Andrew can hear you.
Yeah, Andrew, can you hear me? Andrew and Penny, are you able to hear me? No, okay. I'll send Sarah. Yes, sorry, yes or no?
Yes, we can now.
We've just got sound.
Oh, terrific. Excellent. So yes, everybody listening, please type in your questions through the Q&A button. Thanks very much. That was a terrific presentation. My first question is, within this framework, if a technology was found to be effective but not cost effective, however was a priority on other bases, for instance an equity priority, and there are several examples of programs like this. It might be adolescent mental health or palliative care for people with non-cancer conditions. Is there anywhere in the framework or what you discuss with local decision makers about how they might work with something that's an equity priority but wasn't cost effective?
Absolutely. So I think I can tell Penny wants to have an answer here, but if I have first go. So equity was actually a very important component of our framework. So it was actually a central component of our framework. Our view would be is that the health economics might inform on cost effectiveness. However, that's only one of the issues that, that decision makers might be interested in taking account of. So what I want to draw a line between is the role of what I see as health economists. We provide the information to decision makers, but it's up to the decision makers to look at the range of evidence, and obviously equity is one of those pieces of evidence that they're going to need to look at before they make their decision. And I think, Penny, did you want to add to that?
Yeah, thanks, Rachel. So in the life cycle diagram that Andrew put up, there's the optimization piece, and I guess it's our view and the stakeholders when we've spoken to people. You can optimize for efficiency, you can optimize for equity, or looking at a balance across those. So we would advocate in the evaluation process that you're making it clear what are those priorities, and that you're also being clear in terms of what you're trading off to achieve particular aims. So if it's equity, if you're trying to increase reach, it's acknowledging that there is an additional cost to doing that, and understanding what that is, because often that's not actually measured.
Yeah, sure. Thank you. The next question is from Tilly Payne in Townsville, wanting some clarification around the process. Specifically, can you advise the geographical dispersion of the health services that you interviewed?
They included urban, regional, rural. We probably were low on remote, but they were across Australia. So we spoke with people through Brisbane, through New South Wales, through each of the states and territories. Tasmania was the one exception. And the reason for that is that at the moment, there isn't a translation centre that is actually located in Tasmania. So the work that we were doing was being funded by the Advanced Health Research Translation Centres and the Centres in Innovation in Regional Health. I have to remember the meanings of all of these acronyms. So we went to each of the states where those centres were located.
Okay, so given that Far North Queensland doesn't have an RTEC, do you remember whether they were included? As I think that's probably what Tilly Payne is getting to.
Okay, so not specifically Far North Queensland, but in Brisbane, we spoke with health providers who are actually delivering health services to Far North Queensland, and they were very interested in the way that evaluations could take account of the local context. So this is where local context is particularly important. So it's not saying that the context of urban areas are standardised across Australia. It's taking account of the fact that even here in New South Wales, what we deliver here in Newcastle is often going to be very different to the way it's delivered in Sydney, because it's a much denser urban area.
Sure. Great, thank you. The next question's from Catherine Harding in Melbourne, and I'll just read it out. There's a comment and a question. Many health services appear to have very separate structures, including workforce methods and reporting structures for, firstly, quality improvement, and secondly, for research. Is this a theme that came up in your work with the health services? And do you see this as a barrier to effective local level evaluation of health technologies? So the different structures for quality improvement and for research.
Yeah, I guess just a comment there. When we were engaging the consultations, it would be clear when we started the conversation whether people saw evaluation as research, or evaluation in terms of quality improvement is evaluation and research is research. And for some health services, that distinction didn't exist, and we needed to understand what that perspective was in the individual health services when we were having these consultations. For our perspective and for the project as we undertook it, we weren't making that distinction. So the quality improvement activity we would include in our definition. We adopted that broadest possible definition. So we understood that health services make that distinction, but for the purposes of the project and the recommendations that have come out of this work, we make no distinction. So it applies equally to quality improvement, etc.
Terrific, thank you. The next question's from Christian Wiley. How is this framework being implemented in local health districts, and how will this evaluation framework be evaluated?
Okay, so we've just had a warning that our internet connection is unstable, so I'm hoping people can still hear us.
Yes, I can see you. Yep.
So in terms of implementation, we were actually, I think, pretty quick out of the blocks. We've been working very intensely with our own local New South Wales regional health partners who's obtained funding for us to initiate some programs to address some of the recommendations from our report. And that work is now spread to a number of centres. So we're actually working with people in Brisbane, South Australia, and now Western Australia on one of the programs, for example, is around having an embedded health economist within health services. So one of the problems that was, we just gave you the high level problems, but what was brought up to our attention quite frequently was that people wanted health economics, they just didn't have access to them. And so and the other component to that was people wanted pragmatic and applied health economics. So they wanted people to understand how the health system works and to be able to work within the way that health is delivered at the local level. So one of the programs it's being rolled out within weeks is going to be an embedded health economist, where we actually place a health economist from our units and from our colleagues in other centres within local health services. We have other programs as well. We're trying to upskill and trying to build capability in health services. And just recently, Penny and I have been engaged by New South Wales Health to actually take the national project and take a deeper dive in New South Wales to see where we could actually improve capability and capacity as well.
Great. So following on from that, there have been many talks about increasing the training in health technology assessment, and you certainly touched on training in one of your recommendations. One of the models that has been put forward is a similar model to the Biostats Collaborative Association model, where a number of tertiary institutions run a number of components of that. And one of the issues as to why that sort of model hasn't got off the ground, that was more for health economists rather than perhaps a broader group of people wishing to undertake HTA training, was that the government hadn't committed to funding a number of places. And so the feasibility of running that sort of course is it's still quite uncertain. Was there any commitment by HSRAANZ to help the sustainability of some sort of national HTA training program?
So I think HSRAANZ is just now thinking about the specific tasks that they are going to take on board to actually help implement some of the recommendations from our report. One of our recommendations, particularly around training, is actually a step before what you've just described, Rachel. I think what you've just described is very important, but it's also about making sure that we do have a national curriculum. One of the issues that came from health services is that, and I'll use the broad term of evaluators, that when evaluators come and to work with them, that they're not used to working in the health setting. And so that, of course, is raising an issue, is that the people that we're putting out through the university system, they might be well set up to be doing high-level evaluations, for example, for Commonwealth and maybe for some state policies. But when it comes to working at the coalface with health services, given that's where we spend a lot of our money, that they're not necessarily the skills that are being delivered within the tertiary institute setting. And so part of our recommendation is actually identifying, so what do health services need? And that a piece of that work is actually being done right now by New South Wales Regional Health Partners, and they've engaged the local university here to actually come up with a better model that's going to be directly relevant to local health services.
That sounds very pragmatic. It sounds really good. Thanks, Andrew. We have another question from Nadine Hillock. And actually, there's a couple of questions, a couple of parts to this question. So first of all, within the framework, did you address cost shifting at all? And if so, how would you recommend evaluators consider the funding perspective at a local level?
Okay, that's a really interesting question. That comes back, and maybe I'm jumping in, I'm hogging the question. Penny,
okay, no.
So this is actually one that that did come up around cost shifting, and it's the way that the health economics is actually communicated to decision makers, because decision makers often want to know which of their service, what costs will they be bearing, and which ones will be passed elsewhere. And that's where we've come up with, we didn't talk much about it, but with the budget impact statements. And so we're actually now just working on some guidelines as to the way that we could improve budget impact statements to actually identify where do the costs fall, and if they're being shifted, to what extent, and to where in the system are they falling? Because some cost shifting might be occurring to patients as well. It's not just between the state and the Commonwealth. So we're actually now looking at using budget impact statements to identify that so it's transparent.
I think the other aspect, just to mention, the cross-cutting theme that was in the diagram about end user engagement. So understanding the stakeholders. So when you're constructing the evaluation, having the relevant stakeholders being parties to that evaluation so that it's transparent about where those costs and outcomes lie.
Okay. And I guess that then leads on to one of the problems that you'd identified is that many decision makers can't fathom the information that particularly health economists give them. And myself, I find this something that probably isn't done very well, or it's communicated in a language that's not appropriate for the audience. And you talked about the budget impact statement really being one way to provide information that is, you know, perhaps more meaningful. Is there anything else that health economists or evaluators can do to ensure that the results of their evaluation are more usable by decision makers?
I think that Penny's last comment was one way, one additional way, which is making sure that the end users are engaged throughout the process of the evaluation. And so while we would include end users, patients as being end users, so would decision makers. And so they should actually be part of that evaluation process so that they have a say in the format and the way that that communication is provided to them and what's actually in that information. Apart from budget impact statements, the other area that we're looking at is how do we develop better business cases for health services? And this is actually of taking some of that health economic information, but combining it with other information that decision makers need. And so some of it might be some of the downstream effects that we're unable to capture, but they still would want to have visibility on. And we're actually seeing that working on, and it's an area of work that I still think there's quite a bit of room to move, is improving those business cases. And in fact, part of the project we're working on now with New South Wales Health is exactly around that.
Great. And there's two more questions here, I think, before we finish up. One from Alice Cairns, and this is a staff and workforce question as well. I'll just read it out. There appears to be a lot of interest in evaluating local services or programs by local staff, but they become quickly burnt out by lengthy ethics and research governance processes and any small pockets of funding granted to do this work running out before these processes are in place. Do you have any suggestions on how we can overcome this in small remote health services where access to research institutes are not readily available?
That is a tricky one, and it is one that we come up with in our day-to-day jobs because we are located in regional Australia and we're often asked, and in fact we're going through a scenario right now with one of our more remote LHDs is coming to us for assistance. And I guess the answer to that is that we're actually working out how we can actually deliver that, because part of it is that they want to be upskilled in evaluation, but they also want guidance from people who are more experienced in doing the evaluation work. The funding issues that they've identified in some of the more regional and rural and remote LHDs are very real. And that's been identified to us, is it's very hard for them to fund a staff member in evaluation, but B, once they've funded somebody, to keep them. And so there's actually, it's not a single issue, it's a broader staff issue, and it's one that, yes, I think we need to do some more work with our colleagues in more rural and remote areas.
Thanks. And the final question is there a copy of the report available from this working group that outlines all of the recommendations? And if so, is that on the Artec's website or ARA's website?
Yes, it is. So I will actually send you a link, but this is the report that I'll put up. It's on the New South Wales Regional Health Partners site. And just after this teleconference, I will actually send a link out if that could be shared with participants.
Terrific. Yes, we can certainly share that. That's all of the questions that we have coming in, unless there's any last minute ones for people who are quick typists. You've gone through the questions that I had as well, Andrew and Penny, so thank you very much for that. Doesn't look like there's anything else coming through. So with that, I'd like to thank you both very much for the time and effort you've made to clearly explain at a high level the state of local evaluation and certainly the plans for implementation as well. It's very welcome. So well done. Great outputs from your working group, clearly.
Thank you very much, Rachel, and it was a pleasure. And our apologies for the IT issues in the beginning of this, but hopefully our message wasn't lost in translation.
Yeah, no, thank you. And the Health Services Research Association of Australia and New Zealand will make this recording available for anyone who had to leave throughout the webinar. And we look forward to next month's webinar as well. And for those of you who are thinking about submitting an abstract to the conference, the closing deadline is the 8th of July. Thanks very much.
Thanks, everybody.
Thank you.